Thomas hasn't been with us for a few meetings, so we'll look into that. Turner Benoit, Hanley Foundation. Turner? Ann Berner, South of Florida Behavioral Health Network. Ann, are you with us or anybody from SFBEN?
Hey, my name's Anthony. I'm here from Southeast Florida Behavioral Health Network.
Okay, thanks, Anthony. Welcome. Ariana Ciancio, Delray Beach Police Department.
Hi, I'm here.
Hi, I saw you earlier. Dr. Anita Kokovas, Executive Director, Community Recovery Hub, the hub of Palm Beach County.
Al, she's no longer the executive director of the hub.
See, I'm always behind the curve on this. Send me more up-to-date information. Do we have anybody from the hub here?
Well, Jill Singer's here and Susan Ramsey is the vice president of the board.
You often talk about yourself in the third person.
I like to do that, and that's my new thing.
I'll
Welcome
jump
to my
I'll
life,
jump
Al.
forward. Susan Ramsey, are you here?
I'm here. I'm pretty sure I'm here.
And that's with FAR.
I'm
Okay.
also with FAR. I have two hats.
I don't believe Darcy's with it. Darcy Davis from the Healthcare District.
I'm covering for all of us from district.
Okay, good. Thank you. Uta Gaziak from Florida Behavioral Health Association.
I'm here, Al.
Hi, Uta.
Hi, how are you?
Good, thank you. Michael McKeon from Oxford House.
I'm here, Al.
Hey, Michael. Tama Kudman, attorney. Okay. Who do we have from the department? Who do we have from DCF? Normally it's Kelly Lee, but I don't believe she's on the task force anymore. So who's here from DCF?
My name's Amber Williams, and I'll be doing the presentation for CORE today.
Thank you, Amber. Appreciate that. All right, Jeff Lynn, attorney.
Hey, Al, I'm here.
Hi, Jeff. Nancy McConnell, CEO, Rebel Recovery.
I am present.
Hi, Nancy. Florida Certification Board, Executive Director Neil McGarry. Neil, are you with us? Okay. He may be tuning in later. Dr. Robert Moran, Family Center for Recovery. Okay. Dr. Rachel Needle, psychologist. Dr. Needle? Okay, she may be tuning in later. Okay, Terrell Pyburn, Coconut Creek City Attorney.
Here.
Hi, Terrell.
Hi,
Michael.
Al.
Hi. Michael Schlossman, CEO, Chief Legal Officer, FAR, Florida Association of Recovery Residences.
Here,
Hey, Michael.
good to see you.
Terry Shapiro, GIA Miami and Vita Recovery. Terry, you with us?
I'm here, Al. Thank you. And I think Jennifer Lee from Hanley Foundation is on the call. I saw her name on there. Maybe she wasn't able to unmute. But you have her instead of Turner, it looks like.
Okay, thank you, Terry. Thank you for that. Nikki Soda, Kennedy Forum. Well, I don't think she's with the Kennedy Forum anymore, but Nikki, you with us? Okay, Dr. John Semenides, Florida Health Institute, FSAM, Society of Addiction Medicine, Florida Society of Addiction Medicine. Dr. Semenides? Okay, this is a first. I think he's been to the last 6 meetings. Okay, Alton Taylor, Drug Abuse Foundation. Alton, you with us?
Stephanie Thompson for Alton.
Stephanie, okay, good, thank you. Jan Toman, South Florida Opioid Alliance.
I'm Lisa Keeler, South Florida Opioid Alliance.
Okay.
Okay.
Thank you. I saw you earlier, Dr. Lori Vinicor, Alliance of Delray Residential Associations.
Here I am. Good to see you.
Good to see you too, Lori. Greg Weiss, Palm Beach County Commissioner. Greg, are you with us? Or is
I am with you. Good afternoon.
All right, you picked a good one. This is a good one to be on. Richard Worms, Investigations Coordinator, Office of the Attorney General. Richard, are you with us? Okay, they must be busy up at the AG's office. He may be tuning in later. Eric Urolano, Integrity Billing Company. Okay. Again, welcome everybody. We're going to get right to the introductions. If you could. Oh, okay. I would like to give a shout out and welcome Senator Darrell Roussan. He's sitting in on the meeting. Darrell's been a champion of this space for years and years, and I've worked with him and really pleased that he could attend. I think we need to get the stats up for the Palm Beach County Medical Examiner and the Palm Beach County Fire Rescue. Good news on that front. This is a snapshot. It's 6 months in. As you may remember, we've had about over a 40% decrease in opioid overdose deaths in Palm Beach County, 2024 over 2023. And we're continuing the trend. Between January 1st and July 9th of 2024, with no pending cases, so this is the same period of time last year, we had total drug overdose cases 214, total opioid OD deaths of 156, which was 73% of the total OD cases, and total fentanyl and fentanyl analog cause or presence of 142, which was 91% of the 156. I'm pleased to announce, although it's still, the numbers are terrible, one death is too many, but the Palm Beach County Medical Examiners reported to us that between January 1st and July 9th of 2025, with 24 cases pending, toxicology reports, so it's not complete as 24 is, the total drug overdose cases were 124, this is death. Total opioid OD deaths at 57, which would be 46% of the total OD cases. Total fentanyl and fentanyl analog cause or presence deaths at 56, which is 99% of the total opioid overdose deaths so far this year. But that represents, in whole numbers, and it's a snapshot, it represents 63% decline over 2024. Now, if we take all 24 pending cases, we make them drug overdose cases, and we also make them opioid OD cases, then we're still 49% down from 2024 in the same period, the first 6 months. It's really going in the right direction. So turning to the Palm Beach County Fire Rescue transports, we've seen another decline in 25 rather, in the first 6 months of 25% over last year. 409 total transports. Now, for those of you who were with the task force when it was the Sober Homes Task Force in 2017 through like 22, 23, back in 17, we had 1,798 calls for suspected overdose. It was the Wild West. It was horrible. We are now 77% below that for the first 6 months of 2025. So hats off to what we're doing here in Palm Beach County. And, hopefully we'll continue to trend downward. Any questions or comments on these updates? I don't see any hands. Let's get rid of that so I can see. Okay. Thank you. Okay, let's move on to FAR, Florida Association of Recovery Residences. We're going to get an update from CEO Michael Schlossman. Michael?
Thanks, Al. I'm actually going to turn it over to Josh Thrasher, our Deputy Executive Director. He's going to present the numbers.
Okay, great. Hey, Josh.
Hi, everyone. Thanks, Al. So just go over them. Are you sharing your screen today or just want me to go over the numbers?
Why don't you pull up the for Marianne, please?
All right.
Yeah, that way we can go back and forth if we have questions.
Okay.
Again, we have a new system in place, so bear with us. There we go.
All right.
Okay. Now let's get, that's how you do it? All right.
Because we went through the browser instead of, yeah.
Right.
Okay, very good. Now give me control here. Okay,
Yeah, go ahead.
Josh, you're up.
Okay, so I still don't see it on the screen, but I can go over.
Okay. What we'll do is if this doesn't work, we'll have you share your screen. But hang on.
Go ahead, Lyndon.
There we go. Can you
There
see
we
it now?
Yeah, we can see it.
Perfect. All right.
Okay.
All right, so statewide, FAR is still continuing to grow with our providers. We're up to 272 providers statewide. 9,741 beds statewide. So that those numbers have kind of been the same for a few months. Our goal, everyone's goal is to really get us to 10,000. We've had some contraction with some very large providers here the last few months. So that's keeping us at that 9,741 bed count. So our levels 1, 2, and 3, that accounts for 5,557 beds. Our level 4 beds, obviously connected to treatments, 4,184. So Broward County has a 30% share of the units, 26% of the beds, while Palm Beach County, our largest county, is 39% of the units and 37.7% of the beds. So specifically in Palm Beach County, we have 106 providers. 3,675 beds. Of those, men are 1,849, 606 women. Serving both genders is 1,194, and then LGBTQ beds we have 26. So level 1 programs, we have 6 beds, 1,700 level 2 beds, 64 level 3 beds, and 1,905 level 4 beds. So, and here's just a breakdown of the counties. You can see Broward, Palm Beach is our largest county. We still have some work to do around the state, but we are continuing to grow and receive a lot of applications and so far. So that's all I have. Thanks, Al. I appreciate it. You're on mute.
Thank you, Josh. Question, if we can bring it back up on the screen, the counties, please. How is it going on the west coast of Florida? You know, I know there are significant numbers of opioid overdoses on the west coast, and have you been expanding in say Hillsborough, Pinellas, Pasco? How is it going out west?
We have a regional coordinator in the Suncoast region who's measuring compliance with our certified providers and meeting any needs that they have, but also getting in applications. So Sober Living America, I don't know if you've heard of those guys. That's an application that she got in. It's going to be about a 200 bed application. We're still working with them to get them certified, but Hazelden Betty Ford, I know you guys know that they're in application, they're in their round 2 phase of documentation. So we anticipate certifying them within probably 30 days, provided that they're still motivated and responsive to our email request to get additional information. So we are growing in that area.
That's great to hear. A question regarding that. I know there were issues back in the day with how long it took to bring a certification to completion. How is it working now on average? I'm not going to hold you to an exact time frame, but what do you estimate?
All right,
from the
so
application to completion?
If a provider has met legislative requirements, meaning passing their level 2s, you know, sometimes there's an exemption that they may have to file, which is time consuming. They have a CRA, they can be certified in 30 to 60 days. So that's provided they're motivated. We give them our template. They have to make it their own, send it back. We do a quick response and turnaround, requesting any kind of additional information or amendments to their policies. So provided they're motivated, it can be 30 to 60 days.
Okay. And since you brought it up, it sounds like you have a number of beds in the queue for approval. And I'm just going to ask a ballpark. Do you anticipate being over 10,000 beds by the next meeting in September?
I anticipate that, you know, provided that there are no more providers that shut down. So we took a big a big hit to our bed count with about 150 bed provider, which, we were getting up there and we were really close, and then that happened. They closed down. So if there's no contraction like that, yes, I do anticipate that.
What was the reason that if you know it, that provider closed down the 150 beds?
So really, they have locations all across the US, and the Florida location was just not profitable, to my understanding, and they wanted to focus their efforts more in New Jersey, Ohio, California.
Okay. All right. Thank you. Any questions from the task force? Let's get out of that so I can see. Okay. I don't see any hands. Thank you very much, Josh. Appreciate it.
Thanks, Al.
Let's move on to Oxford House. Michael McKee, I saw you're here, and I see the numbers look pretty good for Oxford House. By the way, before you start, Michael, I was noticing the 6 level 1 beds in Palm Beach County, which is kind of like several. It would seem logical that because there's a strong presence of Oxford House, which is traditionally level 1, that would probably be contributing to the fact that Oxford, which does not need to be certified, would have a share of beds that would normally be certified. Would that be fair to say, Josh or Michael McKee, either one?
If you're asking me, I think that would be fair to say. Our level 1s, it's traditionally they're going to be attached to level 2, and it would be more like a graduate kind of house setup. And the difference in Oxford House, there's many differences, but one being you have to have 9 months of sobriety or clean time to enter into one of our level 1s. So there's a lot of people that may not qualify for our level 1. So that's why you don't really see as many level 1s as, say, a level 2.
Okay, thanks for that. Okay, Michael, you ready? If we can get to
Is he gonna share his own, or?
I can share my screen if you'd like.
with the technical glitches happening, sure, go ahead.
All right, let me take mine off. Go ahead.
Alrighty. Okay, so Oxford House still going strong, still continuing to expand throughout the state. Currently at 265 houses. A little bit of growth since the last meeting. I took off all of the different cities listed, but if you want to check out our vacancy website, in fact, I can pull it up. It's a pretty intuitive website. It's kind of good in here. And can you all see that?
With binoculars, but yeah, sure.
Okay.
But you can just
But
describe what it is. Anybody has access to this, right?
yeah, absolutely. It's just open on the web, oxfordvacancies.com, and it lists all of our houses throughout the country. And you go by city or go by state and county off of that. We've had one overdose, non-fatal overdose in Pensacola since the last meeting. Everything seems to be going well with our continued reliance on Narcan training, making sure Narcan is in all of our Oxford houses, and really doing a lot of trainings focused on overdose prevention, just common things that and signs to look out for somebody that might be experiencing reoccurrence of use. Checking in and having procedures in place for the membership to check in on each other, all very helpful things. Still widely accepted throughout all of the Oxford houses in Florida. Medications for opioid use disorder. Almost 75% of the houses in the state have at least one member currently at the end of June utilizing medications for opioid use disorder, with over 20% of the membership. So we're very happy that that is going well, and it's been going well for a few years now.
So no small undertaking, getting 185 of our members and alumni to National Harbor, Maryland for our upcoming World Convention next month. That's going to be our 50th anniversary event. Definitely going to be a big one. Have a lot of very great speakers from all across the country. So I'm definitely excited for what that will bring to our Florida membership that they can bring back and share with the Oxford House community. Our state association has started some new subcommittees. They officially voted them in. One for veterans, bilingual, helping individuals that do not speak English, or people with sign language, utilizing sign language. So that's definitely a barrier for some people. It's not a huge population, but it definitely helps. And then parents with children subcommittee. All three of these are really designed to bring about resources for individuals in those populations and making sure that we're connecting across the state on just different things that could be available to them. And then also doing outreach and engaging with the community. And then still the focus of Oxford House is really to put houses in areas where there's going to be good things in place for them to be able to build that recovery capital with jobs, meetings, public transportation, and just employment opportunities, and just giving them every chance of success. But we do realize that there are a lot of rural communities in Florida that might lack in some of these things. And so slowly we're chipping away at finding good houses in some of these communities. And it takes time. Like, we have to really think out that process in a lot of places that might not have everything that everybody needs. And so having to find the appropriate location that might be as close as possible to some local jobs and as close as possible to local meetings and things of that nature to hopefully set them up for success. And so that's kind of our long-term outlook on that. And slowly we've definitely been gaining traction on those rural communities in Florida. And so we plan on continuing to do so.
Okay,
That's
thank you, Michael. Can you go share your screen again and go back up to the top?
Sure.
I got a question for you.
Yeah.
Somebody asked a question on chat that are these Oxford House and FAR, are these organizations for large sober living LLCs or companies or not? And I wanted to you skipped over your total beds, which is 2,375. What's the average number of residents in an Oxford House in Florida?
I believe on our last yearly report, it was about 8.9, so 9 people.
And are most of the Oxford houses, if not all of the Oxford houses, independent of one another? I mean, obviously they're part of the parent orbit with Oxford House, but do you cater mostly to individual houses? If that makes sense.
Don't know that I necessarily know what you mean, but all of the Oxford houses are chartered under Oxford House Incorporated. They have a charter, and all of the houses in Florida are part of a chapter. But yeah, I mean, each individual house operates as its own self-supporting entity, and so there's no business aspect to it. All the houses are just single family homes and considered as such legally, in difference to the private or the for-profit or even non-for-profit FAR certified recovery houses that are operated under a business.
Okay. Any questions or comments for Michael? Okay, seeing no hands, I do want to flip back to the other Michael or Josh, because there's one thing I forgot to ask. Well, the first question from the chat. Do you have a number of houses that are just certified individually as houses as opposed to in a larger group?
I can answer that. You mean one house? We certified that program and they only have one house? Yes.
Okay.
Yes. we do.
All right. And the second question is, we did not mention anything about Matt. I know Michael McHugh brought it up. How is that? I know you've been in the process of an education throughout the state, and I wonder if you could update us on how that's going.
So it's going very well. We've been traveling around the state. We've been having regional meetings also quarterly. It's mandatory, giving them updates. We're also requiring every provider to have a MAT policy, like storage and usage policy. So they have to have that in order to do their renewal, in order to get recertified.
Okay. Any questions before we move on from the group? Okay, no hands. I don't know, Healthcare District. Dr. Andrick, do you have an update for us from the Palm Beach County Healthcare District?
Yes, I do.
Okay,
I'm gonna share a couple slides, really 5 minutes, nothing to take more of your time that is necessary. But I thought that sharing my screen and showing a couple slides about where are we at with the crisis facility would be maybe interesting for the group. So give me just a second. And I will not use the slide mode because I want to run through them. Can you guys see my screen?
yes.
Okay, so I have updates since last time where I presented to you concept of the future crisis center building. Since that time, I am happy to share that we did selected crisis center land. It's a 9.66 acre site just west of Florida Turnpike. You can see here on this slide, this is the Turnpike, this is the Southern Boulevard, this is Benoist Farm. So this piece of land is 9.66 acre land of the future mental health crisis facility. The center will operate 24/7 for both adult and pediatric patients. I talked in more details last time. And we will be offering inpatient and outpatient services, psychiatric services, including on-site pharmacy, integrated primary care. So in many aspects, one-stop shop for the people dealing with all acuity of mental health, from the basic adjustment disorders or spider fears, like one of our psychiatrists says, to the most agitated state. This is going to be Baker Act facility as well. Another good news is that we selected program management company. This is our owner's rep as a first step in all those governmental facility developments. This is the kind of order that we do, like selecting first the project management company, architecture company, then the general contractors, right? So I'm just sharing with you to see like what phases we are in. So besides the selecting land, we already had a program management company. And then we also selected architectural company for designing this facility. We don't have a contract signed with this company yet, but this was extensive research, 15 original proposals that we had. We narrowed down to 3, then the committee selected Arcadis as the favorite of not only the final committee, but also short committee that started with those 15 companies. So we are currently working on execution of contract with this designing firm. They also partner, Arcadis was very impressive to us because they partner with human experience company that is a specialty consultant. So those are the people who are very familiar with behavioral health facilities, their needs. They built few of those state-of-the-art crisis centers across the nation in the last couple of years. They're also building, Arcadis is building the NYU Wangun facility in downtown West Palm, and some of you are familiar with that. So they are like big company of 36,000 people, but they have also very important local presence that we also valued. I have a couple slides talking about why we think they're really the great partner for this project. Because they are behavioral health innovators, because they focus on clinical interventions, creating flexible spaces, because we are building this for future generations. So we don't know, like, if you're going to need to scale up or down. So that kind of like flexibility is very important when we are planning this. They're also really known in this world as innovators, also with the products with manufacturers. And then they are so deep into behavioral health that they believe that the good design and safety provides safety features, but is also very high, of course, on all our lists. This is another slide that just represents some of their recent facilities that they built. And then again, this human experience partner comes in tandem with them, and their experience in behavioral health is most impressive. Again, this is just some of the pictures from their proposals. What I like a lot is this quote, and I kind of selected that for you here, how it is important to think even about the future maintenance of those facilities when you think about mental health of this size and scope. They call it like bucket maintenance that is important for them. And they say that, I'm going to read this. One of our favorite phrases is bucket maintenance. Anything that can be fixed with just a bucket of paint or sealant, for example, is going to improve care. Maintenance can limit their time of the unit. I mean, people who are doing maintenance, right? And avoid bringing any dangerous tools into the care environment. We believe that everything in the building needs to be either extremely difficult to break or extremely easy to repair. We bring that mentality into every product decisions. So I will stop here. That's all slides wise that I had. I just kind of wanted to share my own excitement and my company excitement about this development. I think I skipped the slide, and I can share the slide with you that our board approved $145 million for this project. There is a lot of contingency in this. I think around 25-30 million is contingency because there is a lot of unknown in the next 3 years with all tariffs and everything. But the good news is that's reserved in our reserves. So, this does not depend on any federal funding or cuts or future grants, although we will be very aggressive in securing as much funding we can for future operations or supplemental of those reserves. That's good news I had to share.
Well, that's really something. Dr. Hendrick, what's the estimated time frame for the opening?
So we say 3 years. Many of those things that you've seen on the slide is hiring the project management company, and in the same time already posting for all those architects and general contractors. Like we are trying to kind of duplicate efforts in the same time, right? To kind of cut some of those time, but 3 years is the earmarked. That Palm Beach County secured $10 million for this project. We are kind of closing on the land sometime in August. It's $17 million only for the land. So, when we presented to the county securing those $10 million, we kind of cut from 5 years to 3 years. And we want to keep that promise, but we are really trying to maybe make it 2 or 2.5 years with all those kind of duplicating efforts in the same time, and all hands on deck. We hired a consulting company also to help us mainstream some of those things, so we really execute in the highest possible speed.
Okay, thank you. Any questions or comments? Any hands? No hands. Okay. Thank you again, Dr. Hendrick. And let's move on to item number 3. The core program, which, Dr. Hendrick, this is a good segue, because the first program that spawned, I'd say, the core program around the state was our addiction stabilization unit. And congratulations to you for being ahead of the curve for the healthcare district. But we do have, let's see, we have, oh yes, Amber Williams is here to give us an update on the state core program, which, you know, I'm eager to hear how many counties it's in. And I also want to give a shout out to Dr. Shepke, who was part of the initial movement through DOH to get the addiction stabilization unit going and to bring the core concept into the state of Florida. So anyhow, Ms. Williams, you have the floor.
Very much. And I'm so thankful also for Dr. Shepke as well. I know that there's an extreme amount of pride that y'all have in the core network that we now call it. So I completely understand that. I've been able to work with this since we onboarded the additional 17 counties. So I'll go ahead and share my screen and get started. So again, I'm very excited to be able to share with you what's going on. We have made some exciting new advances with the core networks, and let's go ahead and dive into this. It's not letting me go forward.
Do you have it on your?
I have it. She's sharing right now.
Ms. Williams, would you like us to go ahead and put it up there?
That would be great.
Okay, let's do that. And then you can just let us know when to advance the slides.
Absolutely.
Meanwhile, I'm gonna, while we're doing this, I'm really looking forward to the September meeting because I know that that the department is upgrading your system with new software, and the website is going to be, and I'll say, kind of like the ACA website. So it's going to be much more user friendly. You'll be able to find out everything about individual providers much more easily in the behavioral health space. And you know, like I said, it's been a long time coming. I know Senator Harrell was very involved in this, and I applaud the department for the upgrade. And I'm looking forward to your presentation in September. And now I think we've got the screen to share.
Can you see this?
Can everybody see the? Somebody respond. Can you see this on your screen?
No.
I can.
No.
You don't.
We see you, Al. We see that. We see you and everybody else, but we don't
Well,
see the screen.
you can advance my slide as much as you want. It's still going to be the same me. Yeah, how about that? Any better?
All right, give me a second.
All right, we're still working. All right. Nope, that's the wrong presentation. That's the next one.
I know. Second.
Okay. Let me know when you see it. I think it's coming up.
All right, I have that open, and now here we go. Now can they see?
Can you see it now?
Not yet.
Yeah.
Nothing.
You need to bring IT back. All right.
I can definitely talk to you about this in the meantime, and maybe there's a couple of slides on there that we do have some data that our epidemiologists and researchers did have, and they're more of the full year. I know that in the beginning you shared some information from 2025, but they they've condensed it down to the full complete years to give some information. But one of the things that we are doing with the department is definitely moving towards making sure that we're given some incentives and ways that we can increase how the core networks work. So some of the things that I will talk about, and I know that everybody's very familiar with this, and I know that we've kind of moved away from program into network because of the way that the department is moving with things. And again, we are so very fortunate that we get to model this after Palm Beach's model. And
Ms. Williams, I hate to interrupt, but could you kind of like go to step A and just explain what the core program is?
Absolutely.
For anybody who doesn't know. I know we've talked about it for several meetings, but just give us an ABC.
So what the core network is a coordinated system of care. And what we're trying to do with this is to make sure that we connect important partners within the community. And that would be our EMS providers. We have recently initiated, we want to include law enforcement in this as well. Emergency rooms, our long-term treatment centers, and we utilize our peer recovery community organizations and the peers to do those warm handoffs, because that peer aspect of a core network is very important, because we do need that lived experience that helps a person feel comfortable to go from one step to the next step. So the way that a core network is designed to work is that we incorporate a diverse team of professionals. So we want to make sure that, at the emergency room, there's something that the emergency room already does. The emergency room is going to respond to an emergency when somebody comes in there. But with the core network, we want to take it a step further. In an emergency room, we want to be able to initiate medication assisted treatment at that time. Because sometimes what happens is somebody will go to the emergency room, and it happens that, and I hate these terms that we've used in the past, but treat them and street them. We don't want to do that anymore. What we want to do is we want to go ahead, treat a person, and then give them the resources to go into long-term treatment. Because when a person asks for help, that's when we need to move. So if a person goes into emergency room, they will be able to be initiated to medication-assisted treatment. If EMS picks them up, they would be able to be initiated into medication-assisted treatment. So we do have a lot of our EMS providers, especially with the initial 12. I'd have to say that EMS has definitely been a delight to work with in a core network, because they are so passionate. One of the biggest things that we've heard from our EMS providers is that they're very excited about being a part of a core network, simply because usually all they get to do is see the emergency aspect of this and never get to see a person again. But when they operate in a core network and they are providing that treatment via medication to a person until they can get connected to a long-term treatment provider, they are able to see an outcome. So that is very exciting to them to be able to see that. So we do have a lot of excellent EMS providers that are out there and going that extra step and making sure that they're connected to services and giving that warm handoff also with the peers. And then law enforcement, we see this as a new way, because a lot of times law enforcement, people encounter law enforcement in crisis situations. So they could be that first person encounter to treatment. So we know that there's crisis intervention training that's offered to law enforcement. That way they can offer that compassionate care. And we want to be able to make sure that they have those connections, that they know what their core network looks like in their community and be able to offer those resources versus them having to get involved in the criminal justice system. And then, our receiving clinics are long-term MAT providers. These are essential because we need that connection to continue treatment. So making sure that each one of these hands are connected, that way we can get them in that long-term treatment that offers them all the resources that they need, not only for medication-assisted treatment, but also mental health services, connections to anything that they're going on, maybe housing, food, any of those resources they would be able to connect them with. And all in that is those peer services. Again, those are integral. We really are committed to making sure that our recovery community organizations grow, and also the peer workforce. Does anybody have any questions so far? So we want to make sure that we have those access points. So I'm on slide 7, if you want to put that one up there.
Can you see it now?
I can see it, and you can go directly to slide 7, and that's where.
Okay, let's go to slide 7.
So
All right.
All right.
So these are the access points. This is what we want a core network to look like. We want a person to be able to get that treatment at any one of those places, or a referral, something. So, through emergency medical services, through law enforcement, through the receiving clinics, through the recovery community organization, or through the hospitals. And that's what we're looking for, those multiple pathways, no wrong door approach to people receiving care. You can go to the next slide. So these are some of the key accomplishments and some of the initiatives that we have for the core networks for the coming years, because one of the things that we're looking at is we're trying to make sure that we are being innovative in the way that we are spending the opioid settlement dollars, that the money that is appropriated for core networks is being put out into the community for our providers and being utilized. So with one of the first things that I'll talk about, all 67 counties are now will have launched or be onboarding into the core network for fiscal year 25-26. So that's quite an accomplishment. That's full-wide, statewide implementation, and we're very excited about that. We are experiencing new challenges because the last counties that will be onboarding, 20 counties this year, are in some more rural parts of Florida. So we're looking at ways that we can improve even those smaller counties. And then something that we're also working on is strengthening partnerships by including law enforcement being an integrated part of a core network. We feel like that is strengthening those partnerships within the communities. Because one thing that the most important thing about a core network is that coordinated system of care. So we want to make sure that we're including every leg, every opportunity for a person to be connected to services. And another thing that we looked at was performance-based incentives. We want to be able to give rewards for top performing core networks. Because we are seeing some very committed services. We're seeing some very innovative ideas coming out of these counties and our service providers, and it's very exciting. So we want to have definitely a way to reward them. You can go to the next slide. So this next slide just shares what it looks like now. And what it looks like now is every county having a core network. And it shows you the breakdown year 1, 2, 3, and this year. So all of the counties in orange will be onboarding this year. And again, these are a lot of our rural areas. So we're excited about making sure that they get connected. We may even look at like some tri-county situations where they may have to include resources from their neighboring counties to make sure that they can provide the services. And you can go to the next slide. So one of the things, and you can go ahead, I think they've got it where it pulls down everything. You can just click till they're all there. But one of the things about law enforcement is we know that this looks different for everybody. And that's one thing we have learned so much about our core networks is this looks different in every county. There are no two counties alike. And that makes perfect sense because we have different needs in different counties. So the ways that we've listed here as far as a way a law enforcement officer can be a part of a core network. They can do all of it. They can do some of it. We just want them to be a part of it. So, being a bridge to treatment, that's that connection that I was talking about earlier, being able to connect people in crisis to care services. Community engagement, we know that there's a lot of community engagement that our officers have in the community. So being able to promote that core awareness is definitely an integral piece to me. Crisis intervention, we know that happens every day on their jobs. And being able to have, again, those resources and be able to de-escalate substance related encounters with compassion. Again, that's where that CIT training comes in. And referrals, direct individuals to treatment. We want them to be able to know, what are those resources available? Where do they go? What is the next step? Cross-sector collaboration. We need that partnership following up. In some of our counties, in the north region, actually, we have a few teams that go out into the community and they will check up on somebody that either had a connection with law enforcement or had an overdose. And they have a social worker, they have a police officer, and they have a peer, and they go out as a team to check up post overdose or crisis with people in the community, which is absolutely phenomenal. And they go out in plain clothes. I mean, that makes a difference too. Sometimes the uniform can be scary, especially if people have encountered or are involved in the criminal justice system. So again, first link in the chain of care. We see this often, that officers often initiate that recovery journey. So we are happy to be able to involve our law enforcement officers in the core networks. We started off, we sent, there's money in there to, I think, fiscal year 25, 26, we will have initiated all counties, all counties with law enforcement. And you can go to the next slide. So this is the core incentive program. And this is something that we worked closely with. If anybody knows Christy Anderson, she is phenomenal. She has lots of ideas, and we worked very hard to come up with some ways that we could reward people. And then we worked closely with our epidemiologists and our researchers. And what we're going to do is we're going to be able to give monetary incentives for, number one, a decrease in opioid caused deaths. So the county with the highest population adjusted percentage decrease in opioid caused deaths can earn an additional $300,000. And this will be every year. And so again, I said population adjusted because we want to make sure our smaller counties are able to receive this incentive as well. So we are already looking at who that will be for fiscal year 25-26. And then also our top performing counties. And that we've come up with some metrics that we are utilizing. And again, those are population adjusted, so we can award our smaller counties that have equal opportunity to earn the extra $200,000. And that will be for the top 10 performing core networks. So you could be one of the top 10 and have the highest decrease in opioid caused deaths and get an extra $500,000 that year in your core network. And we'll continue to do this until we need to change it, because we know that this changes. We know that while we're working through this, if we're doing our job, then we know that these numbers will continue to decrease. So that's something that we are trying to be very innovative about and continue to have our eye on what's going on in our communities. You can go to the next slide. So this is that data that I was talking about that our epidemiologist came up with. So I'll just give, this is the Florida Medical Examiners Commission drug report. So in 2023, there were 4,995 opioid caused deaths in the 30 core counties. So this is just for the 30 core counties, which makes a 9% decrease from the previous year. So beginning in 2019, the number of opioid caused deaths in Florida had been gradually increasing until 2022. And that's when the opioid caused deaths began to decline. So the 30 core counties demonstrated a decline in opioid caused deaths in 2022, and both of which are consistent in 2023. So in 2023, there were 449 opioid caused deaths in Palm Beach County, which makes 2.5% increase from the previous year's count of 438. So we know that sometimes those fluctuate, but you can see in the next slides that I'm going to show you where we can see what Palm Beach has been doing and rising to the call of making sure that people are being taken care of. So if you'll go to the next slide. So this is from our EMS data. So beginning in 2021, there was a gradual decrease in the number of emergency medical service responses to suspected opioid-involved overdoses in Florida, which remained consistent through 2024. Based on data from emergency medical services through the biospatial dashboard of the Florida Department of Health, there were 23,221 emergency medical service responses to a suspected opioid-involved overdose in Florida during 2024. This is 12,718 fewer responses to suspected opioid overdoses by emergency medical services compared to 2023, and that marks a 35% decrease statewide. So there were 19,900 emergency medical service responses to a suspected opioid-involved overdose in the 29 counties during 2024. So this is 11,209 fewer responses to suspected opioid-involved overdoses by emergency medical services compared to 2023, and that marks a 36% decrease. So the similar pattern was reported in Palm Beach County, with 597 fewer responses in 2024 compared to 2023, and that marked a 31.4% decrease. So you can go to the next slide. So this is also a breakdown, and this was the top 4. I know that this is out of the 30 counties. So again, this is not even taking in consideration who onboarded last year. So several of the 30 core counties demonstrated a reduction in the number of emergency medical service responses, and compared to 2024 to the previous year. Manatee County had the largest decrease in emergency medical service responses to a suspected opioid overdose in 2024, and that was 529 fewer responses compared to 2023, marking a 54% decrease. Pinellas had 2,031 emergency medical responses to a suspected overdose in 2024. That was a 2,059 fewer responses compared to 2023, with a 50% decrease. Brevard County had 1,245 emergency medical service responses in 2024, and that was 1,011 fewer responses compared to 2023, with a 45% decrease. In Palm Beach County had 597 fewer responses in 2024, marking a 31.4% decrease compared to 2023. You can go to the next slide. So these are again, our 30 participating counties. This slide represents our key highlights. So it's the most current full year data available. We should have our data available hopefully by September, after our epidemiologist gets through going through everything and getting all the information, which would also gives us the opportunity. We'll be able to announce who will be the recipients of the incentives. So over 24,000 emergency calls involving individuals with opioid use disorder were responded to by core first responders. Naloxone was administered during more than 23,500 overdose calls by core first responders, and core receiving clinics or long-term treatment providers served over 28,000 individuals with an opioid use disorder. And you can go to the next slide. And this just shows our highlights between the 29 counties and then Palm Beach. And you can see there's definitely the total numbers of what has happened in between April 2024 and April 2025. Check over here really quick. And that pretty much concludes it. Does anybody have any questions? I know you might have to pop through there for the rest of Palm Beach County to show up on that slide. There you go. So that does conclude everything. We've made all counties that are onboarded or will be onboarded this year. Hopefully we will be getting those contracts in place as soon as possible. I know that Stephen Teal, he works closely with me as the subject matter expert in our unit for our core networks, and he works closely with the onboarding networks. He's a retired EMS provider, so firefighter, so we're excited to be able to work with him. And all of our other, Dr. Shepke, he's given us valuable information to utilize with our network. So we're very thankful and hope that this presentation shows you just what we are trying to do in the state.
Ms. Williams, I had a couple of questions and one clarification from if you were on and saw the Palm Beach County Fire Rescue Transports the numbers that I was talking about earlier. That's only for the county fire rescue. So your numbers would have all fire rescue, which would include all the municipalities.
Yes.
It's less than half of the total. So for those of you who are actually paying attention and not sleeping during the first update, that's a fraction of what the entire county, but we've been going down. I did have a question about the incentives. First, where do they go? Do they go to the county government? Do they go to?
They will go through the managing entity.
Through the managing entity. Okay,
yes.
Great. So SEFBEN would be the ones to receive it. Okay, and it's interesting because you highlighted 23 and 24, and that was the only year Palm Beach County went up. I think we went up about 6% or a little less, 2% or something in the past 8 years. So we missed out on some incentives before the program started, but this year we're looking like we're actually, we don't have the 24 numbers yet. That's coming out in December, January. But we've been seeing a 40% decrease in 24 of opioid overdose deaths. And right now in the first 6 months, as you saw, it's really like the bottom's dropped out. That may be across the state, I don't know. But clearly in Palm Beach County, we've seen a remarkable decrease. So we're hoping that Ann Berner can get some money from the core program and use it for what is the core program now in Palm Beach County? You heard that we're building a new receiving facility. Is it still the addiction stabilization unit through JFK and the healthcare district? Do you know, if you know?
You know, I think I saw Stephen on the call here, but I know that this is more Anthony. He's got his hand up. I know that he knows for sure.
You may know the answer. Anthony, do you know the answer?
I can kind of give you, yes, an update of where we're at in Palm Beach County with implementing core. So we currently have a pending agreement with West Palm Beach Fire Rescue that is pending approval from the Board of County Commissioners that they are going to be able to do, they have all their protocols in place, which are very similar to the ones that were developed in 2017. They're going to be able to do pre-hospital inductions and any transports. And we're going to start with JFK North as kind of the initial startup for this. We have Rebel Recovery on board. We work very closely with them. I know Nancy's on the call, so she can kind of give an update. There's kind of some extensive background screening that peers have to do in order to respond to core calls at HCA hospitals. And Palm Beach County Fire Rescue already has a mobile integrated health team where they're kind of doing this. And we're planning on utilizing some of this funding to kind of enhance that and then expand to other hospitals in the county like St. Mary's and then the other HCAs down in Delray and those areas. We actually on July 29th have another core partnership meeting for Palm Beach County. I kind of in the last task force meeting, I kind of plugged the one for the end of June. That was last month. So I could drop my email in the chat, and anyone who's interested in coming to that, they can. It's going to be at Palm Beach County Fire Rescue location. We are, we work very closely with a lot of the MAT providers that are already in our network, like ARS. Obviously, the healthcare district is going to be heavily involved. And again, I can't emphasize enough the hurdles that we're trying to overcome in Palm Beach County, as everything can be very kind of siloed. So us as the managing entity are very much trying to make this a collaborative effort, and we're at the very early stages of Palm Beach County. So again, I'm kind of one of the lead staff members for Southeast Florida Behavioral Health Network taking this on. I work very closely with Houston Park and Amanda Busman to kind of implement this. So yeah, it's a very I don't want to say overwhelming, but it is a large task for us.
Let me ask you something, Anthony, because this task force has grown up with this issue from before 2020, when the healthcare district was trying to put together that program that actually was the basis for core throughout the state. And one of the problems that we ran into was the public-private partnership, where the hospital involved in the addiction recovery, stabilization unit, I'm sorry, the hospital reduced or eliminated the beds that were dedicated to the addiction stabilization unit. You're talking about JFK, you're talking about hospitals, and I open this up to Ms. Williams as well. One of the problems is, how do you, without having control of the beds, for the critical beds, the stabilization beds, how do you create a program when the hospital may at any point eliminate that resource? You may not have an answer. This may be one of those questions that just goes into the ether, and people think about it. The worst thing to see, in my opinion, the worst thing to see in a good program is when you don't have control over your crisis beds, so that all of a sudden you're no longer 24. You may be 24/7, but you have no place to put somebody if they come in and they're in crisis. So, again, I don't think there's an answer to this at this meeting. I see Nancy McConnell's got her hand up with Rebel Recovery, and if she's got the answer, or if she wants to say something else, just chime right in.
I was actually going to try to plug Nancy, because this was one of the concerns that we currently have. So,
okay.
Well, going back to Al's question about the beds and having enough beds, it's kind of going how we did it in the beginning. Okay. In the beginning, the main thing was that the person would get transported to the hospital, the ER, after an overdose. And at this point, we're looking at paramedicine to hopefully get people treated and their first induction of buprenorphine before they get to the hospital. So they get to the hospital, they get another, and within a couple hours, they can be stabilized. And during that time, it's going to be, the peer is going to be called, we're going to be on call now for 7 days a week, 24 hours to have people available to go to the hospital. So it goes back to, like, not a pun, the core of this program, how it started with me, Houston, a healthcare district and all that. It is getting the person there quickly, getting them stabilized quickly. And what we knew in the past, we thought it had to be like 8 hours, 8 to 16 hours to stabilize them. Where now we know we can get them stabilized pretty quickly on the bupe within hours. And the peer is there with them once, when they get to the hospital, the peer will be with them and the peer will help, where they're going afterwards. Meaning that we're looking for beds as not in the hospital, but places where they can go. But a lot of people don't need a bed, a residential bed. They need outpatient, they need support, and they need the peers.
I'm so glad you said that, Nancy, because that is exactly what we want with the core network. We're not looking for, with the core network, it's supposed to be low barrier access to treatment, quick. Not that someone has to go inpatient treatment, because one of the things that we know for sure is that when we require somebody to be inpatient, this is one of the drawbacks for people to get into treatment, is they cannot leave. We have a lot of people who are functioning and utilize substances. I know as a person in long-term recovery, I held a job and I still used substances, but I still needed to come off of that. But you don't want to leave your kids, you don't want to leave this, but you still need some help. So it's low barrier access to treatment is what we're looking for. And that means that it would be quick. It's that handoff. It's from one to one to one. So it should not be an issue with crisis stabilization beds as much as, I know that that's something that we've done in the past, because I know I've worked in MAT programs where we held a person for 3 days to do an initiation to medication assisted treatment. That shouldn't have to happen now. If there are no issues with everything, this should be a very quick thing. And it's a handoff, because that's what we need. Is we need the peer. We need somebody to walk that person through.
Yeah. When I brought it up, I was referring to crisis beds in the hospital for a brief period of time, but it's good to hear that the early induction and stabilization will make a crisis bed less necessary or not necessary. I do welcome Dr. Andriek if she has anything to add to this, because if we're seeing
Ryan, can you please coordinate what's needed?
whoever's not muted, please mute yourself. Thank you.
Okay.
My only question was, making sure we have that warm handoff and that people are inducted. And that leads me to my last question for Ms. Williams. Is everybody induced on MAT, or 50% or 90%? Do you have a ballpark as to the MAT aspect of the core program in its current state?
That is something that we're looking into most assuredly, because we do want to see how many people are utilizing medication. There are sometimes that we do see sometimes, and this is an education piece that I'm sure that I know we're going to be reaching out to Dr. Shepke because the education piece is that we don't have to put somebody in inpatient treatment, do a detox, and then only provide naltrexone to them. Gold standard treatment, methadone, and buprenorphine. So we're looking at more of an education piece that needs to happen statewide, because we do still have providers that make people wait, have to go through the detox, and that's just not the way that we want to operate, because we know what is effective and what is not effective.
Okay. Well, thank you.
Can I say one more thing?
Sure,
And from
sure.
my experience doing this is that when we started in 2017, we were focused on people who had overdosed from opioids. And so they had to have that in their system to be part of the program we had. We're going over to healthcare district and stuff like that. There will be times that people they'll have an opioid overdose, but it could be a severe and they would have to be admitted for medical reasons. We're focused on the opioid part to get them stabilized, so when they get out, they're not in active withdrawal, number one, and they're automatically put with a person, with a peer that can help them get into if they have a habit with opioids where that's their main thing, we can help them if they want to get into an outpatient treatment. What we need is the very, very low barrier treatment. So like Miss Williams was saying, there's people like, if you can stabilize their heroin use so they don't have to get up and worry about a fix every day to feel better, they can get on medications and they can go on with their lives. The how quick the changes were when we first did this, because I wasn't so sure about it, but I saw within days people who had been on, you know, the ramps on 95 and hadn't been taking care of themselves for years, within 2 days stabilized and cleaned up and wanting to go to work. So it's important that we have the places that people can go and get their medication, where they don't have to go to groups every day, and they can, you know, if they're using marijuana or something else, okay, let's work on that, but they're not going to take away their medication, and they're not going to say, well, until you do this, we're not going to give you that. So that's another part of it, the really low barrier of medication.
Thank you, Nancy. I see Dr. Shepke, you have your hand up. Go ahead, sir.
Well, thanks. First, let me say thanks to everybody on this call, and how far have we come in the ensuing years when we first started this in Palm Beach County. Even just to have that talk, just having folks like Nancy and Amber speak of how MAT is actually the gold standard, as opposed to some pariah that was looked at as a failure, that you're, quote, not clean when you're taking a medication prescribed by a physician. And the science is crystal clear that these medications save lives and keep people from relapsing. There is no chronic disease that doesn't have some relapse, but to see people go from a chronic disease where they're expected to take nothing to a chronic disease where they have this very effective medication, and when combined with all the wraparound services that we just talked about, and Nancy, 100% correct. So many of these folks can just do this as an outpatient, which we already proved with the healthcare districts model. It's just very rewarding. I want to thank everybody, especially the local folks in Palm Beach County, where of course I'm from, and Amber, thank you for leading the charge at the state level and getting this out to all the counties. I will say that EMS and emergency medicine are the two pieces that we really need to concentrate on, because that's the front door for this disease. Happy to help with the education with my DCF colleagues. So I'll go around. There's still too many emergency physicians that are reluctant to prescribe these medications or don't know enough about prescribing those medications. I'm going to add one extra piece, that our hospitalists also need more education, because I've seen firsthand how patients who have been stable on these medications come in and get admitted for some other reason. And the admitting physician will continue to prescribe all the other medications, whether it's cholesterol, blood pressure, diabetes medicine, but stop buprenorphine when they get admitted to the hospital. And one other last area where we can work on improvement, and I'm happy already working with law enforcement. Let's get all of our correctional institutions. You literally have a captive audience, and those folks should all be put on these medications as well. Thanks so much, Al, for everything you're doing, what everyone else is doing. Thanks so much.
Thanks, Ken. I see that, Amber, you have your hand up as well. Did you?
I
And
would like to say this because I will tell you with our unit, so I'm the supervisor over all of the opioid settlement for treatment. So that includes peer workforce development, recovery community organizations. This is also jail bridge. So these are all court diversion, hospital bridge, all of those things. This initiative to get everyone involved, definitely. So if there's anything that we can do, and we definitely want to work with our community partners, that we are moving to make sure that all of these pieces are working together. And so, yeah, we already have some things going with Jail Bridge, so that's wonderful. We have a few contracts out there, and we already have some providers that were already doing it, which is wonderful. So people are being able to be treated while they are incarcerated, and then being connected to services when they come out. And also the court diversion program, that's necessary. Court diversion needs to happen because not everybody needs to go to jail. Do they need help? Absolutely. Sometimes a crime is committed because a person is under the influence of a substance. That was the thing driving that. And we need to be able to offer that treatment, because without the treatment, the behavior won't change. So yes, if there's anything like that anybody needs, has any questions about, feel free to contact me.
thank you. And by the way, I do want to give a shout out to our sheriff, Sheriff Bradshaw in Palm Beach County, because he's got, as Nancy can attest with Rebel Recovery, he's got a very vibrant MAT program in the jail. It's kind of gallows humor to say it's the largest detox facility in the county, or maybe the state even. But shout out to our sheriff. And Terry, you had your hand up. You want to close out this part of the meeting, and we can move on to legislation?
Yeah, thank you, Al. I just wanted to say the same thing Dr. Shepke said. It has come a long way. And Amber, thank you. Your presentation was phenomenal. And Nancy, for your great work. Keep it up. Al, you and I attended a meeting with the DEA probably about, I'm going to say this probably over 4 years ago now, probably 5 years at this point, in which they talked about the drugs being seized on the street are no longer fentanyl and opiates being number one, but amphetamine products, and they warned us that it was going to get worse, and it is getting worse. And I'm just, I hate to be the wet blanket on the party here, but we've got a lot of work ahead of us as we play whack-a-mole, because the 2C, which we don't even know, you compare 3 samples of 2C found in the street, and what you find in each sample, it could be different. And we've got a lot of work ahead of us when it comes to dealing with patients with amphetamine-induced psychosis, marijuana-induced psychosis. And this task force has a ton of work in front of us, I think.
You're right about the whack-a-mole. Thanks, Terry. Okay, we just want to make sure we have our IT standing by. We're going now to the and by the way, thank you, Amber. Thank you so much. A great presentation. We're going to the legislative part, which is the last part of the meeting. We have a quick piece of legislation that we proposed last year. It was filed, but unfortunately, due to politics within the legislature, it never went anywhere in the House. So we're going to be refiling this, and then we'll move on to the Chapter 419 rewrite and Dan Lauber. So let's get the first SB 464 from last year up on the screen, please. And I'll have Michael Schlossman. Would you just reiterate what the goals were on the 3 sections in SB 464?
Sure. And if it's easier, I actually have it pulled up, Al, if you want me to share my screen. Okay. All right. So like Al said, this was last year's SB 464. And there were a couple of changes. Let me go to the first one. So this is in 397, 311, 5D. And as you probably all know, I believe we're the only state in the country that has our NAR levels of support that are codified. And so there was a change to D, and anyone who was involved in writing this knows that it's being misinterpreted. It was meant to differentiate between a client-driven referral and a provider-driven referral. And so we're cleaning up some language in there to make it more clear. The next change was in 397, 487, 8E. The way that it read was a credentialing entity shall revoke a certified recovery residence's certificate of compliance if the certified recovery residence provides false or misleading information to the credentialing entity at any time. We had proposed to change this to a May statute, which didn't go anywhere, and so we're quite happy adding this, which adds some willful intent. It would have to be revoked only if it was willful, knowingly, and intentional. Under 397, 487, 3, subsection 2A, we're proposing to strike, which would eliminate the exemption for managing entities to be required to have FAR certification.
Okay.
Was there something else?
Yeah, what's the reason? I want to go to this one and the one before. What's the reason for requiring contracted managing entity recovery residences to be certified?
Well, I think listen, everyone on this call has spent so much time in the creation of the Sober Homes Task Force at first, and then the elevation of FAR, and in 2015, the appointment of FAR as the certifying entity. And the whole idea here was to raise everything to a national standard and to have some real sort of set standards across the board. And Oxford, there's only two exceptions. One is for essentially Oxford houses, which is more of a federal issue, and the other is for managing entities. So we'd like to continue to raise the bar and have every recovery residence certified to a national standard. And so FAR had offered, if finances were the issue, FAR had offered to forego the fees on those for at least a year, so that we could get all these places certified.
This is kind of redundant because don't the managing entities throughout the state of Florida require FAR certification?
Well, and that was another interesting point, Al, is that our talks with the managing entities revealed something quite interesting, is that when they were providing housing assistance, it was required to be, in most jurisdictions, it's required to be used in FAR certified providers. But when the managing entity is financing the provider directly, that provider doesn't need to be FAR certified. So there was a little cognitive dissonance there that we were looking also to clear up.
Okay. And you were waiving the fees so the finances wouldn't be the issue.
Yeah, I think that, we don't want to let finances hold us up from continuing to raise the bar, lower overdose deaths, increase recovery times. And so this was a meeting halfway, maybe more than halfway, quite frankly, in a good faith attempt to make sure that everybody's playing on the same elevated playing field.
Okay. I see, Terry, you have your hand up. Is that from the last issue, or do you have anything you want to comment on for this? Okay.
Just lowered my hand, Al. Sorry.
Okay, perfect. Anybody have anything you want to add or talk about regarding last year's SB 464, which we will reintroduce this year? Okay, now let's move to the last subject. Many of you, if not most of you, know that there has been a legislative paid study that was done for the state of Florida for community residences. By way of background, and we have Dan Lauber, who's the national expert, and a national expert. I'm not going to say the national expert, but a national expert in this for the last 50 years. And he's lived through the Fair Housing Amendment Act amendments of 1988 and the ADA. And primarily, we in this task force have been interested in behavioral health. But you can't like carve out, if you're ADA, if you're FHAA, it's every disabled person, every group home that emulates a family, for example. We have a statute, chapter 419, which is archaic. I don't know whether it was 40 years ago or somewhere around there, when they didn't even consider substance use disorder, because that wasn't considered a disability back when our statute first went into effect, our chapter. And the buffer, the distance requirements, there's a lot that actually violates federal law. And with regard to that, when each individual municipality or county is on their own, we don't have a uniform standard for how zoning with regard to the ADA and the FHAA is handled. And we've had municipalities sued in Palm Beach County and had to fork over almost $3 million because of violated federal law, their NIMBY zoning code. So by doing the study, it paved the way for legislation that can be comprehensive, raise the bar. It's not perfect, and there are some issues, especially economic issues. I know there's some question of that, but for once, we will have a system in the state of Florida where, if properly distanced and certified or licensed, a recovery residence or any home that emulates a family for the disabled is a permitted use, and that don't have to go through the reasonable accommodation tortures of the damned. And it kind of like, if all the boats float when you do this. So that's my introduction to Dan Lauber. If you read his CV, it'll take you 2 days, because it's chock full of real stuff that he's been doing for his entire career. And he's been one of my gurus. We have a couple others that are on this meeting, but when it comes to planning and zoning, the guy knows his stuff. That's my opinion. And Dan, we're going to set this up on the screen for you.
Hey, well,
can you do that?
I'm happy to share my. I think it might be easier if I share.
You want to share? You go ahead, because I know we had a problem the last time.
Is it visible?
Nope.
No?
Nope.
It's coming up, Dan. There it is.
There it is. All right. Perfect. I'm muting now.
Yeah, as long as I share the full screen, it works. If I share just the window, Zoom just flickers rapidly. You could have a fit from looking at it, seriously. Okay, thank you. And thank you to everyone for all the work you're doing. It's really groundbreaking, and I do work in other states, and I wish they would emulate what Florida has been doing and FAR has been doing, but it's hard to get them to pay attention to what is going on in another state. I'm going to I realize the meeting's getting long. I will try to keep you entertained and not cure insomnia. But I'm going to do an overview of what's wrong with currently in 419 and how to cure it. The underlying principle that we have to pay attention to in any zoning for community residences, and the zoning for community residences has to cover all community residences, not just some disabilities and not just some community residences. Even HUD and DLJ recognize that in their joint statement. The underlying principle is that you have to make a reasonable accommodation in state and local zoning. It's got to be fact-based, but it's really got to be intended not only to achieve a legitimate government interest, but it's really got to accomplish that legitimate government interest. And you've got to use the least drastic means needed to actually achieve that legitimate government interest. 419, as it is currently written, has so many arbitrary and capricious provisions in it that violate the Fair Housing Act. It is scary. These provisions have nothing to do with any legitimate government interest. And when some of them seem to have something to do with legitimate government interest, they rarely use the least drastic means needed to achieve that legitimate government interest. The statute as it now exists is discriminatory, just like the recently passed SB 954 that applies just to recovery residences, because it covers just some community residences for people with some people with some disabilities instead of all. For example, there's no justifiable or legal basis for the currently grossly excessive 1,200-foot spacing distance between community residential homes. And even more bizarrely, the state statute doesn't allow for a case-by-case review to make a reasonable accommodation to locate within this arbitrary spacing distance, something you've got to do. A lot of the municipal laws don't allow for making this further reasonable accommodation to locate within a spacing distance, because as the study points out, there are plenty of circumstances where it is perfectly reasonable, rational to allow another home within the spacing distance. The law asserts without any basis in reality that locating a community residence within 500 feet of a single family zone creates a concentration and substantially alters the nature and character of an area. That is pure fiction. It divides zoning treatment based on the number of residents rather than the length of residency or the performance characteristics of the home. That's something we did back in 1973 in a Planning Advisory Service report for the American Society of Plan Officials, which was sort of zoning for group homes, beta version 0.5. And as those of you who've heard me before, we're now on zoning for group homes version 20. It makes no sense, but it was the first try. It doesn't provide for Oxford houses or recovery communities, the state law, and it applies spacing and other zoning requirements even when a community residence constitutes a family under the local zoning code's zoning, or there's no definition of family. And here's where most of the cases where zoning provisions have been thrown out. They don't pay attention to the definition of family. The basic principle is that zoning that treats a group home, a group of people with disabilities differently than the same size group of people without disabilities is illegal discrimination on its face. So if the zoning code doesn't define family, you can't regulate community residences at all. If it has a definition of family or household that allows any number of unrelated people together, again, you can't regulate the community residences, including recovery residences, at all, because you'll be treating people with disabilities, substance use disorder, differently than similarly sized groups of people without disabilities. But when a zoning ordinance places a cap on the number of unrelated people that constitutes a family or household, and the Supreme Court sanctioned this back in the mid-1970s in the Belterre decision, zoning can regulate those homes that exceed the cap. So if you have a zoning ordinance that allows 4 unrelated people to live together as a family, any recovery residence or community residence of any kind that has 4 or fewer people is a family. It's got to be treated the same as other families. The city or county can't require a spacing distance. They can't count these towards spacing distances. They can't require a license, even though the state still can. And that's where they fall apart. However, if you want to have a community residence, including a recovery residence with more than 4 people, that's when the Fair Housing Act's requirement to make a reasonable accommodation kicks in. And that's when the zoning kicks in. And you are not, as the 11th Circuit found in the Sailboat Bend versus Fort Lauderdale case, and the 9th Circuit in California, quoting the Sober Bend case, although they kind of don't really understand it, I found that's when you're making the further reasonable accommodation that's needed under the Fair Housing Act and the ADA. The study that I did for the state, which had extensive collaboration from a number of the people on this at this meeting, would repeal the provisions of 419.01 that violate the Fair Housing Act and replace them with provisions that are in compliance. It would follow the case law, so it would set out an exemption for those community residences that meet a definition of family, or the city or county doesn't have a definition of family or doesn't have a cap on the number of people that constitute a family. It would have all community residences for all disabilities treated the same, and would switch it from dividing how you treat them based on the number of residents to treat them based on how they function, how they perform, using functional definitions of family community residence and transitional community residence. It would replace 419 in its entirety with a comprehensive approach. And that's detailed in Chapter 6 of the state report. It would make further reasonable accommodations, though. So keep in mind, spacing distances apply only to be a permitted use. The study makes it abundantly clear that there are circumstances where you adopt narrowly crafted standards based on the reasons why you're requiring a case-by-case review. So if you want to locate within the spacing distance, we make it real clear it's flexible. Exceptions can be made and should be made when the standards are met. That's on page 157 of the study. Provides case-by-case review with narrowly crafted standards when no license or certification is available. And there are groups of some disabilities for which there is no licensing or certification available. The most frightening and dangerous and threatening group are young women with eating disorders. And why neighbors get terribly upset with a group home for that group, I have no idea on earth. It also provides a case-by-case review if you want to have more than 12 occupants in a community residence. One of the fundamental bases of community residences is that they emulate a family, and we can feel pretty darn confident that 12 people certainly can emulate a family. Get to 13 or 14, who knows? This gives the operator an opportunity to show that they can. You get up to 15 or 16, it gets even more doubtful. You get up to 18, 19, it's really doubtful. But you get the opportunity to show that you can emulate a family. And the study specifies ways in which an operator can do this. So they're not left out there twisting slowly in the wind, wondering how they can do it. The statute, as we're writing it, will allow transitional community residences, and I'll define them shortly, in single-family districts when standards are met. And it will define and allow recovery communities as permitted uses in all districts where multifamily housing is a permitted use subject to spacing and FAR certification. It will also amend other statutes that have been a hindrance to, particularly to recovery residences where they're requiring a fire sprinkler system when even the state fire marshal has admitted there's no reason to if people can self-evacuate. And the majority opinion in the court decisions is if you can self-evacuate, there's no excuse to require a fire sprinkler system. This goes back actually as far as 1972 with a legal opinion by the Attorney General of Maryland, well before the Fair Housing Act was amended to add people with disabilities to its coverage. So this is an example of how the forthcoming legislation would work. We're going to assume definition of family allows up to 4 unrelated. If you fit within that cap of 4, you're a family. You're treated the same as any other family. No additional zoning requirements. But you exceed that cap of 4, that's when the code has to make, the state statute makes a reasonable accommodations for community residences using the least drastic means that's needed to actually achieve the legitimate government interests. We divide the community residences into 2 types based on performance characteristics rather than the number of residents. There's a family community residence, which is relatively permanent. There's no time limit on how you can live there. It's typically there's no time limit. Typically, people live in them at least 6 months by rules or in practice. Oxford House, for example, would be a family community residence because there is no time limit on how you can live there. And as the court, I believe in the Cherry Hill case found, people were living in them 5 or 6 years. Then there's transitional community residences, which have a shorter tenancy, limited to weeks or months, typically fewer than 6 months by rules or in practice. And the turnover rates are much more characteristic of what you would expect in multifamily districts. So because of that, we have family community residences. They'd be permitted uses in all zoning districts where any residences are allowed, as long as they are at least 660 feet, the length of a typical block, or 9 lots, whichever is greater, from the closest existing community residence or recovered community. They're licensed, certified by FAR, or an Oxford House charter, and they don't have more than 12 occupants, including live-in staff. If any of these 3 criteria aren't met, then you apply for the further reasonable accommodation, which can be made by a special use permit, conditional use permit, special exception, type 2 waiver in Palm Beach County, or a dedicated reasonable accommodation process that some jurisdictions use. This will effectively make FAR certification mandatory, because you won't be able, because if a recovery residence or later on recovery community, they're eligible for FAR certification, they've got to get the certification. If they fail to get it, they can be booted out. And I'll tell you, there's one city I'm working with right now in Florida, not in the southeast part of the state, where their big concern is all the scam artists that have descended upon them with these phony sober homes that are not getting people well. They have no interest in getting certified by FAR. This statute, if adopted, will pretty much make FAR certification mandatory throughout the state. And I am hopeful that it will lead to an exodus of the scam operators out of Florida. I can tell you that in Prescott, Arizona, which I worked with, gosh, 8 years ago now, when the city adopted zoning amendments similar to this, and then a very rudimentary licensing law, they had 221 unlicensed, uncertified sober homes there in a town of 40,000 only. And it fell down to 50 because the scam artists left. And the other factor was the insurance companies were cracking down and no longer paying $4,000 for a week's worth of $50 urinalysis tests for one person. The other type of community residence is transitional, much more higher turnover rates, less permanency and residency. Those would be allowed in all multifamily districts when they meet the spacing, licensing, and certification. However, they would also be allowed in single-family districts via a further reasonable accommodation, because there are circumstances where a transitional community residence really won't affect the character of the neighborhood. And the study spells out those sorts of circumstances. So this is the overview of the 2 types. Again, the transitional would be, the family would be allowed, community residences would be allowed in any district where residences are allowed, and that would include mixed use districts. And the transitional ones would be allowed in any district where multifamily housing is allowed. Let me make it real clear. When I talk about single family districts, I'm talking about pure single family districts where they don't allow townhouses, duplexes, and triplexes. When I talk about multifamily housing is allowed, that would include districts that are called single family, but they allow duplexes and triplexes and townhouses. So the statute as it's being written will not run contrary to SB 954. So if we are unable to repeal 954, you still can meet the time schedules in there. And the time schedules in 954 should not be read as just allowing a total of 60 days. It's to go through the process. And the application has to be completed before the final time period kicks in. So it could be much more than 60 days if an applicant doesn't submit a full, complete application. Everyone always raises the question about the number of people in a home, and this is very important. The Supreme Court in the Edmunds decision, 1996, ruled that local property maintenance codes, minimum housing codes, building codes that usually include a formula to prevent overcrowding that apply to all residences, you don't have to make a reasonable accommodation from them. You still have to comply with them. The usual formula is 70 square feet of sleeping area for the first occupant of a sleeping area, and then 50, if there's more than one occupant of a sleeping area, they require 50 square feet per occupant. And that's no reasonable accommodation has to be made for those. Then recovery communities, which are the larger aggregations as discussed in detail in the study, that can consist of 100 people or 200 people or 70 people or 80 people or 20 people, whatever, they would not be allowed in single-family districts that are only single-family detached housing, except an existing one could continue as long as they get certification. They would be allowed in all other residential zoning districts, as well as any district where an institutional use is allowed, as long as they're located outside the applicable spacing distance from the closest existing community residence or recovery community, and they are state licensed or certified. In other words, they would have to have certification from FAR. I do know that a number of years ago, FAR denied certification to one of these 96-bed recovery communities for a whole slew of very good reasons. However, if you want to locate within the spacing distance, you would have a case-by-case review as a special use permit, special exception, dedicated reasonable accommodation. We are introducing what Coral Springs came up with very cleverly, tiered spacing distances. So for a recovery community that's say up to 20 people, it's the same spacing distance as for a community resident, 660 feet or 9 lots, whichever is greater. As the number increases, the spacing distance increases because as the size of the aggregation grows, its sphere of influence is going to, geographic sphere of influence is going to grow. I encourage you, download the study, either from the Addiction Task Force or from my website. I know the latest version of it's on my website that's corrected a bunch of typos, and I think the Addiction Task Force will have that version up any day now, if not already up. The details are always important, and while I absolutely encourage you, do not try to read this in one sitting unless you are trying to cure insomnia. It tells you just about everything you can conceivably want to know, including how to identify what a cluster is, what a concentration is, how to show you meet the standards to locate within a spacing distance. It's much easier than you might think. How to meet standards if there's no license or certification available, and how to meet standards if you want to have more than 12 people in the home. We're hopeful that this will receive support not just from the recovery organizations, but also from the organizations representing operators that provide community residences to people with other disabilities as well, because they are being stymied by, frankly, just simply unjustifiable state statute as it now exists. I'm prepared if anyone has any questions about current flaws in zoning to deal with that, but I'll stop there and entertain any questions and see how much further I can confuse and confound you.
Thoughts, hands?
Hey, Al.
Yes, Senator.
Good afternoon. And thank you for that very good presentation. I have a question. The Florida League of Cities was the main opponent to 954, which in its original version contained many of the solutions that our speaker just talked about. And it had to be changed in order to get it through I went on as a co-sponsor when Senator Gruters could not be available to present it in committee. So I don't know whether it was, I think it was changed after my presentation of it in committee. But here's the question, two questions. One, is there opposition from the Florida League of Cities? And secondly, the original version of 954, I think, contained many of the solutions you're talking about.
Well, Senator, I'd be happy to meet with you and explain this in extreme detail if you'd like. But what 954 originally did was eliminate any ability of localities to zone for recovery residences. And it would not have allowed them to require certification. It would not have allowed them to have a spacing distance, which is critical to making sure that community residences do not cluster on a block and do not create a concentration that changes the character of a neighborhood from residential to institutional and undermines their whole ability to achieve their goals of normalization, community integration, and the use of neighbors without disabilities as role models. And if you look in the chapter 5, I think, of the study, you'll see maps that show how in many of these cities, they have gone and clustered and undermined their ability to actually perform their jobs. So this, we with all of this, we go back to the beginning. We heed the wise words of Vincini and The Princess Bride. When lost, always go back to the beginning. And we look at the reasons why the courts, even before the Fair Housing Act was amended in '88, have been ruling that these uses should be allowed in residential districts. But they were allowing spacing and requirements that were rationally based, not absurd 3,000-foot spacing distances that have been thrown out, and requirements for license and certification because there's legitimate government purposes served, namely to make sure that the people who live in these homes who are very vulnerable, including people with substance use disorder, are properly supported, and we eliminate the scam artists. So 954, as it was originally written, just for recovery residences, one, was discriminatory against all the other disabilities, and two, it didn't include the protections that are necessary to assure that these homes, which are very vital, are set up in a responsible way that ensures that they will be able to achieve their goals. So if you'd like, I'd be very happy to meet with you to explain this in more detail.
I'm going to chime in here to answer the other part of your question, Senator. I worked with the League of Cities and the Association of Counties in the last session. They were, as far as they told me, very supportive of this legislation. It's kind of like the rising tide floats all the boats, but it doesn't create a situation, albeit it was multifamily districts, but it doesn't create a free-for-all that you can put as many homes as you like without any criteria at the local that involves the local government. And again, Dan brought up the clustering issue. There are different voices in regard to what's necessary or what's the best case scenario. What this legislation does is it moves the bar so far. Any home that's certified through FAR, and I'll just use the behavioral health, substance use disorder homes, are going to be a permitted use, and that includes all residential areas. When there are a modified spacing distance, it's not a free-for-all that you can put 10 on a block. That was the big opposition, was that this created an atmosphere where you could have in a 25 or 30 multifamily structure block, you could have 15 or 20 recovery residences. which completely changes the nature and face of the neighborhood. What this does, it will, now we do have, this does include recovery communities, which would have 100 or 150 residents. But again, there would be some spacing distances from other communities, and it wouldn't cause a cluster. So the League of Cities, in answer to the long and the short, is that we got a lot of support for 419. We had to pull it because we didn't have enough time to have committee staff go through it and go back and forth with committee staff to make a better mousetrap. So we just decided to pull it last year. But that's the difference in their view of 954 and the 419 rewrite, which we're promoting. So does that answer your question, Senator, somewhat?
Yes, it does. And I would be interested in following up this discussion. And I've worked very well with Senator Gail Harrell and don't mind working with her again on this.
That would be fantastic. Thank you. Jeff Lynn, you had your hand up?
Hey, Al, can you hear me okay?
Yes.
I would just like to make a recommendation for you to consider that we create a breakout group to focus on this rewrite because it is large and voluminous and detailed and complex, and that we don't only get to review it every other month when it's brought before the task force, because I think the vast majority of people here, like it says, they're not dialed into the issue. It's just not really in their lane. It's not clinical, it's zoning related. And so that would be my recommendation, that the people that really have a lot of skin in the game and the most knowledge on this topic, maybe we have a breakout meeting another time where we just go line by line through the entire legislation so that all interested parties that really want to substantively contribute can do so. Otherwise, we could have an entire 3-hour meeting just on this topic where everyone else will be bored out of their minds.
Yeah, Jeff, I don't consider this a sunshine committee because it's not really a committee. This is a task force. I'm going to do a little bit of research to make sure. I've always kind of like treated it. We do an agenda. It's public. It's published. I try to talk to people offline. I'm not a member. I work for the government. I'm a chief assistant state attorney. So I kind of run the think tank. But I'm going to do a little bit of research. What I do welcome is anyone, and I know there are qualified people like yourself that can go through this legislation line by line and come up with changes that we can then all come together and discuss. And I'm willing to have a meeting every 2 weeks if we need to, because we have to get this to committee staff early so that we can do the back and forth that's necessary, because this is groundbreaking. It really does move the bar quite a bit, and you and I have had discussions about this. So I would ask at this point for any individual. So I mean, there's Terrell Pyburn from Coconut Creek. There are several others on the task force that have some knowledge of zoning and knowledge of community residences that you and I can get together for an hour and we can go over this. I'm not totally comfortable though, having a subcommittee off of this. And if we do have a subcommittee, it's going to be a published meeting. So either way, you and I can discuss, but I do welcome changes. And I know that Dan and I have discussed this, that we want to make a vibrant, reasonable accommodation. But right now, the system is so broken that, and you've heard me say this before, a half a loaf is much better than no bread at all. So as long as the concept is something that is supported by both, again, and we have to thread the needle with the League of Cities and the Association of Counties, as well as the economic impact on people who do want to see an expansion for the business model that you and I have discussed. So, yeah, I agree. you and I can talk, and maybe, you could just submit to me what changes you'd like to see, and we can have interim meetings. We don't have to meet every 2 months on this issue. Does that sound doable?
Yeah, again, I wasn't looking for an accommodation for me. I was just trying to find an efficient way to get comments that people could review when we start getting into the minutia. If you want to have a meeting specifically scheduled for that, and people can choose whether they want to attend or not, of course. I just
Okay.
wanted to go
Yeah.
through it all so we can explain it all. So if people have questions, like Senator Rusan or others, they're answered in this more casual environment rather than a committee meeting where there's not really questions and answers up in Tallahassee the same way. You can't, it doesn't really lend itself to the process the way this group does. So, and
No,
like you said,
yeah, we want to have a finished piece of legislation
yeah,
when we get it to committee staff, for sure. And the more voices, the better.
right. That's my point. I want to eliminate as much new issues that could potentially come up from left or right sides over there, on this legislation. This should be bipartisan. This should be statewide. And it's really good work. It's just some little nuances in there that just need to be tweaked, and just want to make sure that we're all, either on the same page, or we can all agree to disagree at least, but at least so they're discussed, so they're not new topics that are brought up in Tallahassee when none of us are around to address them.
Well, I invite you, Jeff, to start redlining and coming up with areas that you want to discuss, and maybe tweak the language some. I would ask the same of Terrell Pyburn. And anybody else, just, reach out to me. I'm there to discuss this issue. Dan, he'll make himself available when it's, efficiently coordinated, because he does have a life and a job. And I see, Terrell, you have your hand up, please.
Yeah, I think an idea. I'm happy to help. If you could just send around the last version where we left off, so that way I'm sure that I'm using the correct version to work from, that would be really helpful.
Everybody has it from this meeting. It's
Oh.
part of the attachments.
All I had with the maybe it didn't come through. I'll get with Mary Ann. Thank you.
Yeah,
Okay,
and Terrell, if you can get that to me too, to be sure, because I saw a link, but I don't have a Word document or anything.
No, the link is to Dan's study.
Okay.
I sent out the actual legislation that was submitted to committee staff last year. So you should have that in your attachments. I'm going to have Mary Ann, just in an abundance of caution, just resend it out to everybody, and it will be posted on our website with the meeting recording next week sometime.
Great, thank you.
Okay. Thank you very much, and thank you, Senator Rusan, for being part of the meeting, and I look forward to working with you as well. Any other questions, comments about this agenda item, Chapter 419 rewrite? Dan, do you want a good and welfare on this, or are you done?
Well, I just like to add this will open up the whole state to community residences with a comprehensive, rational approach that will enable not just recovery residences, but group homes for people with other disabilities to locate throughout the state, because there's a whole lot of cities in the state that have zoning provisions that are excessively restrictive. The state statute is excessively restrictive, clearly in violation of the Fair Housing Act, although didn't want to say that in the study. We were trying to be diplomatic. And this really opens some great avenues to get the housing in there for people with disabilities who need a community group living arrangement to live in, while still assuring that neighborhoods will stay neighborhoods and not get flooded, which would change the character and undermine the ability of these homes to do their job. And I welcome comments from Jeffrey and Terrell and others on refining the ordinance. I actually have started a little work on it myself, and looking forward to hearing from others.
Okay. I'm going to reiterate the fact that one of the fundamental, it's a carrot and stick type of thing, I guess, because one of the fundamental benefits is, number one, the houses have better oversight because they'll be licensed or certified. And number two, there's a permitted use, which doesn't exist now. So it's going to save communities, local government from having to fend off lawsuits, number one. And number two, it will create a system where you don't have to spend thousands of dollars to get a special exception. You'll have a permitted use in most cases. My understanding anecdotally, and Terrell, you can chime in if you like, but my understanding is there have been very few contentious issues in Palm Beach County since in the localities where this type of ordinance has been enacted. Most every community residence has either been grandfathered or permitted use. And unfortunately, I think Jeff Lynn had the clients of all the people that were reasonable accommodation, and there was no guidance, which is another beautiful thing about the 419 rewrite, is to lay out guidance that this is what you need to do in determining whether to grant a reasonable accommodation. I'm going to poke the bear right now, Dan. I'm going to poke you because it has been said the economic model, and it has been said that your view is a dinosaur's view because these studies have been done 30, 40, 50 years ago, or 40 years ago, and that really it's discriminatory, and that these houses, now people don't even know their neighbors anymore. So to have houses haphazard wherever they want to locate is not going to affect the community. And I'm just saying it in the ether, just bringing it out there because that has been one of the arguments that this doesn't go far enough, this legislation, and keep it to 25 words or less, because I really did poke you on this one, I know. But what's your response to that?
The studies which you're referring to are the ones on the effect on group homes on property values. No one's doing those studies anymore because it's like the same situation. Do cigarettes cause smoking? Does smoking cause cancer? It's so well settled, nobody's sponsoring those studies either. And these are it's just very well settled. Second, the so-called economic model you're talking about is coming from one guy who wants to be able to turn whole neighborhoods over into massive recovery residences to make a greater profit. And I say, show me the proof that this is needed. The 4 studies that were cited before the legislature to back it up all turned out to have absolutely nothing to do with what this person was asserting. It was a total falsehood. I've got the studies. Anyone's welcome to look at them. And I dare you to find anything that in those studies that backs up the guy's assertion.
I want to leave that behind us about identifying any particular LLC or any particular person, because I have had the same conversation with a number of people who do want to expand and don't think the legislation has gone far enough. So, but I hear what you're saying. I hear what you're saying is that that's not supported. So I guess that's what.
Yeah, one thing, this legislation doesn't prohibit those sorts of models. It just says you can't. You could take a whole block and turn it into a recovery community, but you're not going to be able to take, as of right, as a permitted use, the next block and turn it into a recovery community as well. There's going to be a spacing distance from that block before you could do another recovery community. That's all this does. And it does not prevent I know the model you're talking about, it doesn't prevent you from doing it. It just says you can't go and do block after block after block after block adjacent to each other and turn it into one massive recovery community.
Okay. I would like to hear from Michael Schlossman, because FAR this does affect FAR, and I want to hear your thoughts about this concept and whether you think it's, and I know I'm not going to ask you on behalf of FAR, because that's something that the board decides, what you support, what you don't support. But if you would, and if you're not comfortable, that's okay too, because I'm putting you on the spot. But just your thoughts about this.
I appreciate it, Al. Thank you for putting me on the spot. No, so as you know, listen, FAR has been very active in this and working with Jeff and working with Dan and working with you. And we had our own statewide zoning task force for a while, and Susan is really heading that up. So I do want to defer to Susan. I will say this, though. I will say this. Every single day, our office gets calls and emails and urgent requests about the myriad zoning regulations across this state, which are sort of neither here nor there. Some are allegedly used for NIMBYism. And we're excited, and I can say this on behalf of FAR, for some kind of statewide sanity. What that turns out to be, I'm not quite sure. There are certain things that I'm personally in favor of that maybe FAR is not in favor of, or back and forth. But I will say that it really is going to help the recovery residents' fields to have certainty that if you own, say, one house in Broward and you want to open another in Palm Beach County or vice versa, that you're going to know what you're getting into before you get there. Because this is very, very difficult, especially our level twos, which are the backbone of FAR. There is so much regulation being put on top of them. And if anyone knows what it's like to run a level 2 recovery residence, our heart goes out to them. Very, very difficult to turn a profit and to have a quality program, especially with some of the layers of regulation that we and others are adding on to them for very good reason. So we're excited that we're having this conversation. We've come a long way from the first time we've had this conversation. There are parts of Dan's study that I absolutely love. There are parts of Dan's study that we'll agree to disagree about. But I'm really looking forward to hashing this out and getting something that gives some surety to us, regardless whether you are in the States. Susan, is that fair to say?
As always, Schlossman is always right.
There we go.
There you go. I agree. And that is absolutely true. That is to have some, exact, like what you're supposed to do, how you're supposed to do it, will help so many folks who are wanting to open or continue to run recovery residents. The devil's in the detail, but we're certainly on the right path.
Okay. We're going to have a meeting to discuss in depth the legislation in August. Jeff, Terrell, and whoever else, Susan, you're a lawyer, you know how to read statutes and legislation. Anything that you want to suggest, any changes that you want to discuss. Dan, hopefully we can do it on a day where you can be there, but even if you can't, that's okay. It will be a task force meeting. We'll open it up to anybody who wants to be there, but I want to have people who are going to want to make input to actually do their strike-throughs and get them to me early with the suggested changes and suggested language. And we will go through every suggested change if we have to do it in 2 meetings. We got to have something. Now, I'm not sure when committee staff opens, but the session is early. It's in January. We cannot get caught in this summertime doldrum where all of a sudden we're in October and we don't have a finished product. So I'd like to have by the end of August something that we can deliver to both Senator Roussan and to Senator Harrell. And we'll find a sponsor in the House, because our sponsor, I believe, is going off to different things. Our past sponsor, Mike Caruso. This is probably the most important piece of legislation that we've worked on, and we've had success in 7 of the last 9 sessions. So thank you. Any closing comments? Thank you very much. It was a great conversation. It was great to hear from Amber Williams from from DCF. I look forward to in September, DCF, she will probably be talking about the new website and the new software. Any comments? All right, have a great week. Have a great month. And if you go to Spain or Italy, bring one of those fans that squirts water on you, and make sure you have enough water in your pouch, because that place was hot. Okay, thank you, everybody. Have a great week.
Thanks, Al.
Thank you, you too.
Thank you, Al.
Thank you all.